Good morning. It's a great honor to be at this meeting presenting some of our interpretations and suggestions regarding what we found difficult in terms of assessing lung cancer, especially pulmonary nodules, and also what we can do to try to reduce the margin of error when you try to assess if a nodule is benign or malignant. I would like to thank very much the organizing committee, Professor Postumus and Professor Cagliotti, for the opportunity and for the invitation. To try to keep in time, this is our group. We have all been inspired by Professor Hans-Ulrich Kautzer from Germany in terms of some of the aspects that are going to be here, and I work in a close collaboration with my friends from Brazil still, because my behavior in the UK may be sometimes difficult for the British people to do. So we still have very, very strong links with a group in Brazil that is very motivated in terms of trying to get diagnosis there. My idea is we are going to try to go a slight description about what we have in the current guidelines in terms of volumetric assessment or assessment of pulmonary nodules, especially the ones below 1 centimeter, to describe the functional image methods that we can use to try to establish a more accurate TNM stage or to define better the probability of malignancy in a pulmonary nodule, and to discuss some barriers, which will be, if you have time, in the end. Yeah? The first thing you would like to see will be regarding the follow-up of indeterminate pulmonary nodules, regarding if you should use subjective analysis, if you should use diameters or volumetric analysis, and what is there recommended for us to follow. We are going to briefly review some about the dynamic contrast enhancement and the uses of that. A brief review on PET-CT scan for lung cancer staging, especially in the results that we can get from that, and some alternatives to the PET in centers that you don't have PET, especially the MRI in terms of lung cancer staging and definition about malignancy of a nodule. And our take-home messages will be concluding the presentation. So one of the things that I think I'm just telling you what you know already is that pulmonary nodules is below 3 centimeters, masses are above 3 centimeters, yeah? And we are not going to talk about nodules bigger than 1 centimeter here mainly. We are mainly concentrating the smallest ones, and especially in the solid nodules. Yeah? The non-solid nodules are very more complicated, very more debatable in many things that you do. And for those, I would recommend you should go to the guidelines of the BTS or other guidelines from your countries to try to identify which is the best approach for the part solid or subsolid nodules. As you know, in the 2015, the British Thoracic Society did a fantastic review, a very beautiful work of about 50 pages long that you would have to try to identify and try to guide you regarding when you do identify a pulmonary nodule, what to do with that. And basically, if the nodules are bigger than 8 millimeters or 300 cubic millimeters, and they have more than 10% of risk of malignancy, you should consider PET or further investigation to try to define malignancy at that occasion. You shouldn't wait. If it's between 8 and 10, or 8 millimeters, cubic millimeters, or 300 cubic millimeters, you should then consider low-dose CT in 1 year despite the risk of malignancy. And if they are between 6 and 8, or if they have more than 8, but they have less than 10% of risk of malignancy by the Brock module, you should do a follow-up in 3 months as an initial action. The British Thoracic Society suggests that you should use volumetry. And we are going to see what we have experienced in terms of trying to use volumetry. But they also recommend that you should assess your own software and your own scanners to see how the results are. And that's what we have done and what we are going to present here. So this was a case that I have probably was triggered Professor Postumus to invite me to present here, of a patient with a pulmonary nodule identifying in a CT pancreas with 3 phases. Yeah? So those 3 images are from the same nodule, same day, 1 in 3 different sequences there. And the nodule changed in volume from 35 cubic millimeters to 108 cubic millimeters in the same day. So this patient came for the follow-up, yeah? And in the follow-up, it measured 76 cubic millimeters. So then we said, okay, so what we do with this result? Has this nodule shrinked from 100 cubic millimeters? Has this nodule increased from 35 cubic millimeters, or is this nodule stable? So that is the main problem that we face. And if you look the segmentation, when we passed through the segmentation, it was a good segmentation. Yeah? Because one of the problems with segmentation is that many times it fails to really circumscribe the nodule, and you have extension to the chest wall, extension to vessels. But in this case, it was absolutely pristine, the thing. If you carefully look to these images, you're going to see that the degree of inspiration that this patient took was slightly changed. Yeah? Slightly less inspiration in the one that you have the largest volume. And this more or less explains one of the biggest problems we have in volumetry, is that the machine uses attenuation values to define what is the nodule or not. Yeah? And then if you have collapsed alveoli surrounding a nodule because of the lesser degree of inspiration there, you may have a highest volume, which may not be real in terms of comparing to the maximum inspiration. So if I would say which is the actual volume of this nodule, I would go for the lowest, because that was what you probably have. Yeah? So if you're going to use volumetry and you have measured in different sequences there, consider the lowest. But you know that in the follow-up, if this would happen, you would be stuck, because this nodule has certainly not grown in few seconds there or few minutes between each scan, but in the follow-up, you could say that it has increased 3 times and you need to remove that. So we extended this analysis to a more robust review of cardiac CTs where nodules had been identified in more than 1 sequence in the same day. And that's what our results, where you have found an average variation of 17% with the software we use. And this recommendation of the BTS guidelines of 25% increase in volume as the threshold between stable or growth is in the percentile 75 of our confidence error of 5% of confidence error of the variability in the same examination. In this situation, if you look, this is the threshold for growth in volumetry, 25%, which is around the same 75%. So when you use this threshold, you know that 1 in 4 nodules, at least with our software, you would say that the nodule has increased in volume, and it actually has not. Yeah? It was just a limitation of the technique. So when you call growth based in volumetry, if you use software similar to ours, you do need to be aware that you may be overcalling 25% of your patients as the nodule having been expanded. Well, in 2016, in the USA, the NCCN has issued new guidelines, and they have decided not to use volumetry for their guidelines. This is mainly for lung cancer screening. And they now actually use the average between the longest and the transverse diameter of that longest diameter in the same axial image to try to identify if the nodule has increased or not. And they then decide a little bit different thresholds in regards to what to do with the nodules. But it depends on where you are. You do need to follow one or other guideline. Yeah? We need to follow the BTS in the US, in the UK. The criteria of growth for the NCCN is more than 2 millimeters in size. So if you don't have volumetry in your software and you are going to use volume dimensions, yeah, I think the NCCN guideline is reasonable for you as an alternative to volumetry. If you use those 2 dimensions, average them, and then more than 2 millimeters in growth, you have the condition of this nodule has increased in volume. And they have based this in this work from 2004 from Revel. So that was regarding pulmonary nodules, trying to identify which ones we should follow, what is growth or not. And now trying to identify which nodules do you think are malignant, which nodules do you think it's benign. Yeah? So getting rid of those classical patterns of macroscopic fat, diffuse calcification, or central dense calcifications, you know that the CT scan has a poor specificity. Yeah, it can be as bad as 28% when you try to say if it's benign or malignant. And some people say that they can reach 100% of specificity, which I doubt, but anyway, it's there in the literature. So one of the easiest way to do if you don't have access to the PET is try to use dynamic enhanced contrast medium. There's the Swenson technique that you all are aware of that, because this is there for many, many years. And if the nodule has increased more than 15 Hounsfield units between the pre-contrast and the dynamic assessment, you would say that this nodule is benign. Yeah? If it has increased more than 15 Hounsfield units between the non-enhanced and the enhanced phase, then you say that the likelihood to be malignant has increased, and you do need to decide. But as you see in the graph, a lot of benign nodules will enhance more than 15 Hounsfield units. The dynamic enhance has other advantages, not just for that, but if you have two phases, you increase your chance to assess chest wall invasion for the TNM stage, you increase your chance to assess pleural dissemination, and you increase your chance to assess extrapulmonary metastasis. And also, it also increases the chance for you to define which lymph nodes in the mediastinum are suspicious on top of just the size. More recently, you have the dual energy CTs. Not every center has dual energy CTs. We have, but we use very little, unfortunately. You can see that you have a good correlation using volumetric assessment of the enhancement of the nodule. You have a good correlation with angiogenic factors, which helps when you want to decide to put other drugs in the treatment of these patients. PET-CT scan is certainly what is more established as a helpful tool to proper stage lung cancer patients. Yeah? And in relation to define if the nodule is benign or malignant, there is this new change or suggestion from the BTS guidelines that you should consider 4 categories there: absent, faint, moderate, and intense, trying to define if the nodule has a higher probability of being malignant or benign. Yeah? Then this is a little bit more complicated for us to compare, but just for you to know that we now just compare with the background of the uptake in other structures to see the probability of malignancy there. The PET-CT scan, as you see, is not perfect. Yeah, we all have problems with that, but it helps a lot when you want to differentiate what is tumor, what is consolidation, non-tumoral consolidation. Yeah. And to define if you have mediastinal and chest wall invasion, sometimes you can have, but certainly is not as good as the CT or MRI in this sense. The PET-CT SUV, when you put a cutoff of 7, SUV of 7, you have a good help in terms of defining the prognosis, and you see that if the SUV is less than 10, the chance of you to be alive in a year is 75%. If the SUV is more than 20, the chance to be alive is only 17%. So it's a very important information that you can get from the SUV on the PET-CT. But as we've shown in this paper we have published some years ago, the number of false positives for malignancy is high. Yeah? All these cases are benign lesions which have been surgically removed or biopsied, and were all benign lesions. Yeah? This one here was an aspergilloma, which is bad. And you all know the false positives that are well known, like TB, sarcoid, fungal infections, brown fat, degenerative changes. You all know that it has also a lot of false positive cases. You see the size of this lesion with low metabolism, which is false negative on PET. So as anything in medicine is not black and white. It's always a shade of gray, always a change. But it helps a lot if you want to do radiotherapy planning. And also helps to decide in the early phase of your treatment if this patient is responding to that treatment or not. As you see that if you has decreased the SUV of a lesion in less than 10, probably the survival will not be as good as if the decrease of the SUV has decreased more than 10 after starting the chemotherapy treatment. The other thing that you need to know is PET-CT for nodes, has a sensitivity of 74 and a specificity of about 76. So similar to what we have the pulmonary nodules, 1 in 4 is wrong, when you do that. What you have, if you don't have PET available, you can try MRI, We are very confident that MRI can help you a lot and can replace the PET if you don't have one, If you have one, the guidelines suggest you should use the PET and not try these new techniques that are not yet completely established. To detect pulmonary nodule, the MRI scan can be as good as 96% of sensitivity, even for small nodules, but then you need to gate for respiration, you need to gate for cardiac rate. One of the very important things to define malignancy or benignity of a lesion in the MRI scan is when you compare the diffusion of the lesion using a high B above 800 or 1,000, and then compare the sign of the lesion with the sign of the spine, as you have there, in the high B. And then this ratio has a very good area under the curve for definition of sensitivity and specificity for malignancy. We have repeated the study, and we found even better results using 1.2 as a cutoff point in the ratio between the lesion and the spine signal, going to an accuracy of 94%, which, as you see in the end, if you get a larger sample than we had, it will be around 85 and 90, The MRI is good for the TNM staging, but it's not as good as the CT for T1 and T2. It's better than CT, probably for T3 and T4. It's very good for chest wall invasion, very good for invasion of the diaphragm and invasion of mediastinal fat, better than PET, better than CT. The accuracy, again, 1 in 4, we may be wrong, In relation to the T of the TNM, you see that although the p-values are not very good, there is this indication that higher T are better seen and better staged in MRI, lower Ts are better staged in the CT scan. For the N study, the MRI is something that we are getting very excited about, but we still need larger studies, And you see that the pulse specificity of MRI seems to be slightly better than the specificity of PET, but the studies with MRI are still too small to be really extrapolated to the general population. In terms of the M, as you know, MRI is better than the PET-CT in relation to the brain metastasis and liver metastasis. And when you compare whole body PET MRI with whole body PET-CT with MRI of the brain, you still have an advantage of both 4.2% in favor of whole body PET MRI, which is not widespread. It's even less than the PET-CT, but it is one of the possibilities you have. When you compare whole body MRI with PET-CT plus brain CT, so you increase your accuracy there. So what should we take to home today? That although the recommendations suggest that you should use volumetrics for assessment of the pulmonary nodule growth, in our software, we found that our confidence interval should be 45% of variability if you want only 5% error that we use for most of things in literature. If you want to use the guidelines, you need that it shows that more than 25% growth. You are telling that 1 in 4 of the nodules said that there is a growth. When you use our software, you are going to be over-diagnosed in growth. You'll be interacting with those patients, which may be justifiable because you don't want to miss lung cancer in the treatable phase, but you need to be aware, and your clinicians need to be aware of that. The NCCN guidelines uses dimensions, average dimensions, longest and transverse diameter of that longest in the same image, and more than 2 millimeters in change is the definition of growth. We don't have the same analysis yet for the NCCN guidelines, but we are going to do it. PET-CT perfusion is useful for angiogenic correlation. Delayed CT is used for you to assess mediastinal invasion, pleurometastasis, and metastasis in other organs. PET-CT is the gold standard, and the message from the BTS is that you shouldn't use PET-CT, shouldn't use MRI or dynamic CT, enhancement CT, if you have PET-CT available to try to define malignancy, to try to define the staging. Yeah? But there is a very promising avenue towards the MRI scan, not necessarily linked to the PET. You can do that without the PET, but you do need to fight with the cardiologists and with the MSK people. Thank you very much for your attention.